There you go. It's done.
So no, so like what I can't do is pin. So hold on. So let's say I make, so Maria, can you start talking?
Yeah. You can either pin or you can put speaker view. That should do the same thing. So do you see me in big and then a gallery of people up?
So see right now, I see all of us still.
Okay. You don't have the view option in the upper right hand corner.
I do not.
What if you click on my face and 3 dots and put pin?
I still see all of us.
That's weird. So your
I
pin
know,
is
Carol, even when you run your mouse up on the right-hand corner, that little, you have to run your mouse over it.
Like honestly,
It's not coming up, eh? Weird. Because it's hidden for sure.
and like I was doing this with Iris all the time. Like I don't know.
Yeah.
Who started this meeting?
Me.
Maybe you're not the, are you the organizer?
Carol, do you want to make Anne-Marie host, which will allow her to record but then will you be able to share the screen? I think you should be able to.
I think Carol, let's just go with it because there's a problem with recording and I don't.
Yeah, you're right.
So let's, I think we'll be fine. People will change their screen to what they want anyways, too.
That's true. It's just for the recording, I guess, but it shouldn't be that big of a deal.
Yeah.
Okay.
So we can let them in.
So we have a whole bunch of people. We have 18 people. Okay, I'm letting everybody in, okay?
Barry, you're kicking this off, right? Nobody's saying anything. You're chief boss now.
Okay. Just wait 1 minute while people are joining.
Can you hear me?
I can hear you.
Oh, good. Okay. Hi, how are you?
Yeah.
Oh my, I should change. I'm using my son's computer. Should I change my name?
You can keep whatever name you'd like there.
Thank you. It was so nice to see you.
Nice to see you, and you're among a lot of friends, you can see.
Thank you.
So welcome.
Hello. Hi, Barry. Hi, Carol,
Hi.
Maria.
Hey, everyone.
Hi, everyone.
Hi.
Hello.
We're putting IMC to shame, I think, today. We have more IMC members here than they do. Well, welcome, everyone. I think we should get, in the interest of your time and want to respect our schedule as well. I'd love to get started and to welcome all of you warmly and to thank you all for your ongoing support, not only of Colorectal Cancer Canada, but of Ready for the Next Round. We really appreciate everything that you do, and as do our patients, because without you, we would really have some serious challenges, and it really does make a difference in all of our programs. And we know that you're well aware of the impact of the pandemic on our healthcare system. So we're not really going to talk too much about that.
I will, Barry.
Yes, Elia will, and we'll introduce you in a second. I think actually we have our animator, Anne-Marie Wright, will be facilitating with us today, and she'll make some of these introductions, especially Elia and Maria. Many of you have met them. When the pandemic was kicking in, we also held a patient conference, and we had a guest speaker, Greg Simon, who some of you may know kicked off and ran the Cancer Moonshot in the United States. And he challenged all of us to say, you know, if they could create a vaccine in 90 days or so, what can you do to impact the healthcare system in Canada? And what can you do together with others to collaborate to make a difference? And so I started thinking about that, and our team started thinking about that. And early on, one of the first things that we did do is we put together with partners a advertisement or a campaign letter and pardon me if you hear some background construction noise, that's what's going on here. But we put together this sort of campaign that said, ready for the next round. How do we prepare our healthcare system for the next round? How do we prepare our healthcare system for to avoid the shock and interruptions in our healthcare system? So we did the ad, and then we thought, well, what more can we do to better understand and appreciate what is going on and what we can do to make a difference? And we put together 4 thought leadership roundtables, and among patients and physicians and healthcare system people and researchers. And we came up with several themes that developed in the area of virtual care and data health technologies, real-time metrics and data sharing, evidence-based decision-making based on that, and public-private partnerships as a possibility for investment in research, and some of the work that we talk about with the Canadian Health Research Forum in our discussions on Patent and Medicine Price Review Board with the government and all the opposition parties as well. Patient-centricity in cancer research, how this can make a difference, and investing in more personnel and training, and really developing a better national strategy for provincial collaboration. And at the end of that, we said, well, we got to get started on some of these projects, and one of which I'm really proud to say we're going to be advancing in terms of a live data dashboard with our researchers in Alberta. We started as well to work again on pushing the message that people have to get screened during this time with partners again. And we'd like to collaborate with as many people and coalitions as we can. And of course, we do play an integral role with the Resiliency Healthcare Coalition as well. But today is not so much about that. It's about telling you about these 4 thought leadership roundtables, which you've seen the executive summary of. And Elia and Maria will talk to that. And at the end, to get your comments, your input to the extent that you can, and to try to help determine how we can collaborate better together in order to achieve some of these goals. So with that, I want to thank you again for all of your support and for being here today. And I'll pass it on to Anne-Marie Wright, our wonderful facilitator, who will help coordinate from here. And I'll see you at the end.
Thank you so much, Barry. And it's great to see some of the faces that I have known through CCC over the past little while. Thank you for joining us today. I wanted to briefly introduce you to both Maria and Elia, if you don't know them, although I suspect many of you have had wonderful interactions with them. They have been the masters of this initiative. They have brilliantly guided the organization through a wonderful volume of work that we want to share with you today. So the way we're going to do this is to spend about 40 minutes sharing with you an executive summary report of the outcomes. We'll take a brief break between Elia and Maria to answer any what I call questions of clarification that you have. It would be a big miss if we did not engage this wonderful group in some conversation about that report. And while we only have 20 minutes today, we have a few questions that we hope you'll participate in and guide the organization in this next phase of development around this initiative. So without further ado, we're going to first move to Elia, who will take the first 3 recommendations. We're going to take a 5-minute, let's call it question period, and then we're going to move right into Maria after that. Elia, over to you.
Awesome. Thanks, Anne-Marie, and thanks, Barry, for the warm introduction. So everyone, welcome to the 5th Thought Leaders Roundtable. My name is Elia. I'm a program manager here at CCC, and I co-led the Ready for the Next Round campaign with my colleague, Maria. And today we're going to be giving a presentation on the findings of this campaign, hoping that we'll have a very fruitful and engaging discussion. So right off the bat, let's start with the mission to remind everyone of what the mission was. So the mission for the Ready for the Next Round campaign is to raise awareness on the importance of uninterrupted cancer screening and treatment, and to find strategies to strengthen health system resilience in order to better respond to future system shocks in case similar crises happen in the future. God forbid anything happens in the future. First of all, that would suck. But we want to be prepared. We want to learn from our mistakes. We want to shield some of our vulnerabilities, and we want to try to, if we can, remove those vulnerabilities and replace them with something that's more resilient. That's definitely would be the overarching goal, I would say. And the vision for the Ready for the Next Round campaign is to build a more resilient healthcare system. And again, a system that can ensure uninterrupted cancer care. And I'm saying cancer in general, because it wasn't just colorectal cancer that was affected. It was a multitude of cancer types that were adversely impacted by the pandemic. And we sort of want to capture the impact of the pandemic on other cancer sites as well. Of course, with a little bit more emphasis on colorectal cancer, because we're the nation's colorectal cancer organization. So it would be funny if we don't emphasize on that. Moving on to the next slide. So one of the major key activities, Carol, yeah. One of the major key activities for this campaign was the Ready for the Next Round Thought Leadership Roundtable, just like Barry mentioned. It's basically 4 roundtables, which is, again, a fancy word for workshops. These were held back in September 2021, and each roundtable represented the views of 4 different stakeholder groups. So we had patients, we had physicians, we had healthcare system leaders, and then we had researchers. And we felt that it's important to capture firsthand experiences of each of these 4 stakeholder groups, because each one of them experienced a different set of challenges during the pandemic. And in order to come up with strategies to combat these challenges, it's super important to take a holistic approach and include everyone in the cancer care continuum, everyone involved in the cancer care continuum. And remember, each group wears a different hat, and their solutions come from their occupation's point of view. So I think that's why it was important for us to invite these 4 stakeholder groups. In terms of the core exploration areas, the Thought Leadership Roundtables aim to scrutinize multiple core exploration areas pertaining to COVID-19 and cancer. The first one being to explore and understand the impact of the pandemic on cancer control and cancer care in general, but more specifically colorectal cancer. The second one would be to spur ideas, strategies, and solutions to address current backlogs and prevent future interruptions in cancer care. The third would be to pinpoint the lessons that we have learned from the pandemic that could be useful to the provision of cancer in case similar crises occur in the future. And then the last would be to find innovative strategies to strengthen our healthcare system and build the resilient design to respond better to future system shocks. These were the main topics discussed, but moving on to the panelists or the attendees, we had approximately 23 attendees. And these attendees included folks from different professions and occupations. So we had patient advocates, nurse navigators, medical oncologists, pathologists, radiation oncologists. I see cancer epidemiologists as well, and of course, representatives from the private and public healthcare sector. And we had amazing discussions, and panelists provided superb insights that we couldn't help ourselves but write a report on it. Moving on to the next slide. So the recommendations that were put forth are based on discussions and expert-informed opinions held in each of the 4 thought leadership roundtables. We basically summed all of these great insights and discussions, and we wrote a very comprehensive report that was submitted to Current Oncology on February 2nd. Today, we're basically going to go over this report to brief you on the findings and what the findings were, aka the recommendations that the panelists provided. A few of you here have seen the report. Essentially, the layout was the question that was asked during the workshop, the recommendations that were provided, and then the summary of evidence to support those recommendations. We're going to do the same thing here. We're going to present the question. I'm going to talk a little bit about the summary of evidence, and then I'm going to present the recommendations that were offered or presented by the panelists, if that makes any sense. But it'll get clearer in a second. Next slide, please. So in terms of target audience for recommendations, it's super important to depict who the recommendations are directed to. Of course, it would be amazing for anyone and everyone to look at these recommendations and see where they could be implemented at their level of practice. But in our situation, we want to target these recommendations at the federal, provincial, and territorial healthcare professionals, researchers, policy advisors, and decision makers who are directly and indirectly involved in the provision of cancer care in Canada. In other words, we want those who can actually make an impact. At the end of the day, we can publish and write about this day and night. But if we don't have an outlet, if we don't have a receiver who can take these recommendations and force a change, then our work would be redundant. And it was just be another publication among the thousands of papers that get published daily. I'll tell you, it's a very profitable business to own a journal nowadays. So if any of you want to start that, I'll drop my information in the chat here. Okay, jokes aside, let's move on to the 7 questions and the 7 themes. So these were mainly the 7 questions that we'll be discussing today. These are basically the main questions that were asked during the workshops. Very briefly, the first is about the impact of the pandemic on the oncology community and provision of care. The second is about telehealth. Third pertains to data and the importance of data, timely access to data. The fourth touches on burnout among healthcare workers. Fifth is about patient-centricity. And the sixth touches on the importance of advocacy group and NGOs amid a crisis. And then the last one debates whether a decentralized healthcare system is most suitable to handle healthcare disruptions in future pandemics. I've got to admit, the last is probably my favorite because it's quite controversial, and controversial topics are quite interesting and entertaining as well, especially during these days. So let's move on to the first question. So the first question was regarding the impact of the COVID-19 pandemic on the oncology community and the provision of cancer care. We all know that the COVID-19 pandemic illuminated a lot of the vulnerabilities in the Canadian healthcare system. It exposed many gaps and challenges that could be turned into opportunities. Basically, we heard it from each stakeholder group, and I don't want to spend a lot of time on this because we all know that the pandemic interrupted and delayed screening. It altered diagnostic services and the way patients are treated. It basically necessitated a logistical transformation across healthcare provision, and that's across cancer centers, hospitals worldwide, and here in Canada as well. And the pandemic continues to this day with the evolving new variants to create massive backlogs that will take years and years to catch up with. So I've provided here a few quotes that caught my attention. This one's by Charlene Gill. She says, and quote, "Capacity and human resources are the issues, not only because of COVID, but because of what is happening with cancer in general. We can pour money into buildings, but it's human resources that we need. We need nurses, family practitioners, oncologists, and surgeons." And I find that quite true, given the shortages in the healthcare personnel that we experienced during the pandemic. And I believe it was BC, I read in one of the news articles that was trying to bring back retired doctors during the pandemic to help treat patients. I mean, how desperate do you have to be to bring in 80-year-old and 90-year-old doctors to treat patients during the pandemic? It's quite absurd. And I'm not trying to bash any province, I'm just saying that out loud. There's another quote here by David Armstrong. He says, and quote, "Even before the pandemic, hospitals in Canada were running at 110, 120% capacity. So to return to former capacity levels, as well as to accommodate backlogs created by the pandemic, will be a challenge. We need resilience within the healthcare system. We also need re-engineering of the frameworks within which the system operates." So good. Super tweetable. I'll tweet this right after this meeting for sure. It's so good and so true. Anyways, we all know what the pandemic did. So let's move on to the recommendation. This is just a summary of the recommendation. There's a lot more in the report. But if we go to the next slide, okay. So the first one was increase human capacity, human resource capacity. So that would mean training and hiring more healthcare providers, whether that's nurses, physicians, radiologists, and so on. And that's in order to expand operating hours for diagnostic and screening endoscopies, as well as other services. And this is super important, and we'll discuss this in another question, but I've seen a lot of news articles recently suggesting that we we should expand operating hours to have healthcare workers work on weekends and extra hour. But again, this was heavily discussed in the roundtables, and Maria will touch on that. Healthcare providers are experiencing major fatigue and exhaustion from having to deal with the influx of COVID-19 patients, and at the same time trying to manage other comorbidities and diseases that predate COVID-19. So perhaps loosening our requirements for med schools and graduating more nurses and physicians could help with that. The second recommendation that was put forth is to expand diagnostic and screening endoscopy services through partnering with private clinics. In other words, be able to utilize private clinics to help assuage with the backlog, keeping essential cancer-related services running amid the crisis. The third one is to optimize available healthcare resources. So for example, opening screening and other relevant services in areas with a low prevalence of COVID-19. This is, in other words, would mean to have something to allow us to easily navigate where the system is overwhelmed with COVID-19 patients and be able to reallocate healthcare personnel and direct patients in need of services to hospitals or clinics less impacted by the pandemic, where they could be seen and treated in a timely manner. Of course, there's a lot that could be done to help mitigate the impact of the pandemic, but I'll just keep it to these three recommendations because they're pertinent to colorectal cancer as well. So moving on to the second question, and this is probably one of my favorite questions as well, because if we're able to access data and utilize it in a timely manner, we can solve a lot of the problems that we're facing today. We can help mitigate the impact of the pandemic on many cancer fronts. And I forgot to read the question, so I'll read it. How did the COVID-19 pandemic influence the healthcare system to invest in up-to-date information and timely access to health-related data? We all know that the current data collection methods for cancer screening tests, diagnostic or treatment procedures generally take years before they become publicly accessible and available. And this inability to respond in a timely manner causes an adverse downstream effects on follow-up procedures, on surgeries, on pathology and treatment in general. And we all know here that we have rich cancer registries here in Canada, but the lengthy collection and reporting process limits their utility and prohibits real-time actionable interventions, and that's a big problem, of course. I believe it was Ava, and Ava's here, so shout out to Ava. She gave an example on how pragmatic COVID-19 dashboards were during the pandemic. Timely data pertaining to COVID-19 cases, morbidity, hospitalization, mortality, and immunization as well. These were super important, critical in understanding, managing, and mitigating the impact of the pandemic on the human, the social, and the economic effect of it. A lot of the mandates that came out and the preventive measures and public health precautionary measures, they came from live data of COVID-19 cases, hospitalization, and mortality as well. I know this might be a stretch because COVID-19 and infectious diseases have nothing in common. Well, they both kill and they're both a burden on the healthcare system, but if we can somehow have real-time or near real-time data on cancer screening procedures by region, by province, it would truly make a lot of difference. Very quickly, I'll read this quote, and it's also tweetable, by Fred Horn. He says, quote, "The important aspect of building data collection infrastructure is its ability to facilitate application of data and decision-making. There should be a continuous loop where clinicians, patients, and policy makers have real-time access to published data as well as real-world evidence that is coming from different parts of the country." I can't agree more with him on this. And let's move on to the recommendations, because I know I'm running out of time and I'll be taking Maria's time if I do that. So a few recommendations that were put forth is the development and the implementation of better and interoperable EMRs management algorithm using common data dictionaries. We know that EMR systems, if individuals decide to change healthcare providers or change institutions, the data can seamlessly transfer between these institutions. It reduces duplication of records, identifies missing patient data, and compared to the traditional paperwork, EMR significantly decreases disease identification, which could, which again is amazing for the healthcare system because it's time efficient and cost effective, right? The second recommendation put forth was the systematic collection of data across health regions to observe trends across groups. The third was to ensure publicly accessible data and research outcome, and that's basically saying we need treatment patterns and we need to know what the clinical outcomes are and have this data available for everyone. Not everyone, researchers, clinicians, and anyone who could actually utilize this data. The fourth one would probably be my favorite one, which is leverage of automation strategies, so AI and machine learning that permit faster collection, processing, and reporting of the data in real time. And I'm a big fan of a Canadian-based company called Blue Dot, and they transformed health surveillance using machine learning and aberration detection techniques. This is not impossible to accomplish on a provincial level. And if the excuse is that we don't have the expertise, then here you go, you have a wonderful Toronto-based company who could do that for you. Other governments worldwide have utilized them, such as Singapore, and the way they managed COVID-19 was much better there than what we're doing here in Canada, in my opinion. Moving to the third question. So should telehealth be the lasting model of care or a temporary measure? This is one of those questions that you see everyone talking about nowadays. The pandemic undoubtedly showcased the value of telehealth technology, and that's for virtual appointments and consultations, and telehealth showed that proper care could be given outside of hospitals, over the phone, over Zoom, or closer to patients' home. But again, not all patients' conditions are suitable for virtual care. In some scenarios, it could be an additional burden on clinicians. And a lot are not comfortable with having sensitive discussions and decision made over the phone. So there's a clear trade-off there in this situation. But for cancer patients particularly, it's important because these patients are considered to be immunocompromised, and you want to have this trade-off between, you don't want to be exposing immunocompromised patients to COVID-19, at least for the initial variants. But again, it should be utilized on a case-by-case basis, and this is exactly what's proposed and recommended. Moving on to the next slide. I promise I'll finish on this slide. So again, since not all patients' conditions are suitable for virtual care, we need telehealth to be further developed. And perhaps a general policy could be implemented to encourage patients to visit in person every second or third consultation. There was more emphasis on telehealth be implemented on case-by-case basis because you don't want to compromise in any way the gold standard of clinical care. Not that patients will be treated over Zoom, but any misclassification or misdiagnosis over Zoom will definitely incur further consequences. I'll leave it here and I'll open the floor for questions regarding these three themes that we just discussed. And my apologies if I exceeded my time. I know that I have 15 minutes.
Thank you, Elia, very much. It's very challenging to present all of that data.
Right, and I know I was going really fast.
Yes, we had sent the report out in advance. I'm not sure how many had a chance to look at it. What we can do is if you want to use the raise hand button on Zoom, if you've got any questions of clarification for Elia, we're happy to take them now. So I'll just give everyone a moment. If I don't see any hands raised, we'll move along.
Tim Marshall has raised his hand.
Perfect, thank you. Hi, Tim.
Hello. You can hear me okay?
We sure can.
The are we allowed to throw out some considerations also, and not just questions?
Yeah, absolutely. Yeah. Absolutely, go ahead.
Considerations in two areas. In the question number one, more human resources. We've been trying to diagnose some of this stuff, and some of the things we're considering are like some of the root cause analysis. We're not clear yet on any of the root causes, but we're wondering if products, the modern therapies, are causing some of the clinic capacity issues and the flow through, meaning the clinics were built in a different era. The current therapies are providing such a wonderful survival advantage compared to the different era. Is part of the capacity issue the fact that the patient pool for follow-up of patients that are free from cancer and hopefully cured are they still attached to some of those clinics? Root cause, what would cause that attachment is that growing pool of fairly healthy patients slowing down the capacity for new patients to come into the system. And then could there be a way to look at how do we facilitate creating an emotional attachment for those long-term patients to their family practice center to have some of their long-term family care looked at the family practice level. So that's
I think this is a great point, and survivorship care plans is something that we don't use here in Canada for post-treatment follow-up and stuff like that.
Sure.
If we could implement survivorship care plans as a standard of care, where all the patient information would be summed in one document that could be given to a family practitioner who can understand what this patient has been through in terms of treatment, diagnosis, stage of cancer, all that stuff, then that could sort of mitigate this impact, and it could help family practitioners to take part of this, right, and be able to follow up with these individuals, which would have less burden on oncologists and other folks who want to see new patients and want to treat patients.
Great.
That's an amazing point. That's an amazing
Yes,
point.
thank you, Tim. I see that, Christine, you have your hand up.
Hello, good morning, Elia. How are you?
Good morning, Christine.
Great presentation. So I had a few
you.
questions that came up. You know me, I'm always thinking about operationalization of things. So just wondering, when you're speaking of, needing to help with human resources and investment from an advocacy perspective, where do you see you playing a role? Do you see yourselves, engaging around advocacy on increased health transfer payments, for example? What would be sort of your approach?
Yeah, that's a great question and tough one for sure. We need someone within the government. We need policies, everything nowadays. And we should learn from the history too, right? We went through this pandemic and we have a shortage in healthcare personnel. This should be a learning curve for us. We didn't learn it from the SARS-CoV-1. We should learn it now for sure. If we think that there's a shortage in healthcare personnel, we should hire more. We should loosen the requirements for med school and prerequisites. I have a few of this is a personal anecdote, but I have a few of my friends who have GPAs 3.98, 3.99, amazing extracurricular activities, well published, still got rejected because of the seats. They can't graduate more, and each province has a certain number of doctors that they can graduate. So if we can play with that, and again, this adds to the additional burden, the financial burden of the system, because the government has to pay these new graduates, and you're bringing in more doctors. But then there's another thing with doctors who are trained outside of Canada, who immigrate to Canada, right? We could utilize those individuals as well amid a crisis like this. I believe Saskatchewan was one of the first provinces to take advantage of that. But yeah, it's a very complex formula here, and there's a lot of moving parts in it, but definitely policy is one of them.
Christine, thank you for your question around advocacy. We're going to cycle back on that in the open session. Thank you for raising it. I'm going to give the last question to Sam, and then we're going to move on to Maria.
And really quick, more of a comment than a question. One would assume that the ability for Canadian healthcare system personnel to stay on top of scientific evidence, with meeting exchanges being limited to online forums, or time being spent away from academic pursuits to manage clinical. I don't know if that was brought up as a consideration, but I think it's an important piece of the healthcare puzzle that should not be neglected because of the Canadian healthcare system being under resources, as you had mentioned.
Absolutely.
So, thank you.
Absolutely. This was mentioned. I believe it was Charlene who mentioned it. We should definitely shift our focus, especially amid a crisis like this, from doing research and teaching and all that stuff to more than go down the route of clinical work in order to help mitigate the impact, at least for the short term. But yeah, great comment.
Great. Great, thank you so much. We realize that we've got a short period of time with all of you. This is just the beginning of the conversation. I want to encourage everybody on this call to write your questions down, write your thoughts down. I know that CCC would welcome subsequent conversations with each of you individually as things progress. Having said that, Maria, we're going to move right into question number 4, and then we're going to come back for a bigger question period and discussion period.
Yeah, thank you everyone, and thanks for being here today. So I'm going to go forth with the 4th question, and that is, how can the healthcare system address and assuage burnout among healthcare workers? So we all know that building a more resilient healthcare system is important and is essential, but we do know that healthcare workers are at the core of the system. And so it's really important for us to know, for them to know that the system is willing to invest in their education, their health, and most importantly, their well-being. So the healthcare workers were exposed to physical and mental exhaustion, burnout, for the torment of both difficult decisions, the pain of losing patients and colleagues, and the risk of infection for both themselves and their family. So burnout amongst the healthcare workers has increased to levels that will actually eventually threaten to dismantle the functioning healthcare workforce. So for example, the shortage of nurses is a nationwide problem that we all know about. Pre-pandemic, the nurse to cancer patient ratio was 1:1. Now it's actually 1:4. And we do know that this is going to be likely exacerbated by the vaccine mandates. So on top of all this, we do know that there was backlog in screening and surgeries. And so this meant that healthcare professionals are constantly trying to catch up on that. And so for example, from a pathologist perspective, pathologists are now seeing a shift in type of samples. They're analyzing more complex samples since these patients are now in more advanced stages. And then at the end of the line are, of course, the medical oncologists who are also now seeing more severe and advanced cases. So as the system tries to catch up and as surgeries resume, healthcare professionals as well as the supporting staff are likely to be stretched to their limits. And I'll quote something that was said in the roundtable by Dr. David Armstrong. He mentioned that we need to be able to allow people to make changes and get a reward out of their jobs. A position in a healthcare system is not just a position, but also a skill set and an investment that needs to be maintained. So next slide, please, which will allow me to show you the recommendations that were put forth to assuage burnout among healthcare workers. First, we can invest in a reserve of trained healthcare professionals. We can increase capacity for training healthcare professionals when needed. So for example, nurses from the medical ward can be trained to care for oncology patients with just the basic oncology skills. We can invest in wellness programs. So this has been done in Alberta during the COVID pandemic, but this means that healthcare institutions across Canada can invest in such programs and create positions such as a chief wellness officer. And basically what this officer would do would be to be responsible to create support for a resilient workforce, but also for a healthy work-life balance amongst healthcare professionals. But also simply just creating a healthy environment for the workers so that they can be not overworked, but also relax, meditate, simply sit in silence, or even take vacation when needed, allow flexibility in work shifts, and last but not least, providing mental health support. Next slide, please. So another question that was very common amongst all 4 roundtables, so this was brought up by each of our stakeholders, was how can a patient-centric approach be one step towards a more resilient healthcare system? So the panelists all agreed that one of the steps towards a more resilient healthcare system is to actually shift the focus towards patients. And I'll read a quote by one of our panelists, Ava. She mentioned that our healthcare system needs to be humanized, and the approach should be predict and prevent instead of wait till it's broken and then fix it. We need to aim for wellness and healthcare instead of sick care. And by measuring what matters to patients, we can respond to their needs instead of having a one-size-fits-all approach based on what's convenient for the healthcare system. Every patient is different, and when talking about personalized medicine, we need to think not only about treatments and drugs, but of healthcare as a whole. So the panelists then discussed the implementation of the new EMR systems, which could provide an opportunity to collect and potentially share pertinent data, including, as we all may know, patient-reported outcomes between jurisdictions. So Fortunately, this is reflected in the recent acceptance of having patient-reported outcomes in HTA as valid outcome measures when deliberating and deciding on funding recommendations. So this leads me to another quote from Tim Hanna, who mentioned that offering high-quality patient-centered care takes time because it involves not only understanding patients' genomics, but also their values, desires, and personal preferences for how they would like to be interacted with and cared for. So as you know, although access to medicine is super important, access to healthy lifestyles is equally, if not even more important. The panelists also explained that the COVID-19 related restrictions led to the decentralization of clinical trials. So this meant that now, for example, it's online informed consent, there is increased remote monitoring, offsite counseling. So that was good because it meant that the trials are now more patient-centric, with research activities brought to the patient's home instead of patients traveling to different centers. But it's important to consider, when we're considering trial decentralization, that patient preference is taken into consideration as well. So traditionally, patients are required to travel to a treatment center for follow-up and monitoring. So decentralization can take that away. And so some of the advantages offered to patients were because of close follow-up protocols. So it has its pros and cons, but is definitely a recommendation moving forward. So just for the next slide, please. The recommendations that were put forth in order to make a resilient healthcare system more patient-centric could be established by providing patients with better timely access to innovative treatments. And this is something that we always try to do at CCC, try to get more drugs reimbursed, but also using patient-reported outcome measures and quality of life metrics, better understanding of patients' expectations and experiences through patient-reported experience measures, developing models linking standard of care and clinical trials with the pros and real-world evidence to develop biomarker-based precision medicine tools and adaptive learning health system approach. I've interacted with most of you regarding standardizing biomarker testing across Canada. So this is something that we're super passionate about at CCC. But as I mentioned, so a patient-centric healthcare system is important, but patient-centric research comes along with it. And that could be established by involving patient organizations in the approval of projects and protocols, implementing decentralized clinical trials, while at the same time taking into account patient preferences and providing timely access to patient healthcare, to patient health records. So next slide, please. Another question that was also reiterated in most of our roundtables was how can patient advocacy groups and non-for-profit organizations support the healthcare system amid a crisis? So we all know that there's an increased need for support services and transition services and institutions. And this was particularly evident during the pandemic. So when the healthcare system was overwhelmed, patient organizations such as CCC played a crucial role in mitigating the impact of the pandemic on patients, survivors, and their caregivers. So for example, a few of our panelists explained that a few of our patients who were also panelists mentioned that they could not bring a family member to their appointments during the COVID-19 pandemic. So they were often in distress or heavily medicated. And this made it very difficult for them to retain any information that was provided to them during their care. So this is where organizations such as Hope and Cope, the Young Adult Cancer Canada, West Island Cancer Wellness Centers, and I'm sure many other organizations really contributed to support. They provided patients and families with information on wellness and their disease prognosis by playing an essential role in improving the patient's well-being and ultimately their outcomes. So it was suggested in our thought leadership roundtables that cancer patients be provided somewhat with a cancer coach. So this cancer coach would be able to provide them with a roadmap of their cancer journey, explain the role of different specialists they will encounter, any support they may need. And so just knowing this from the very beginning, what resources are available could save patients lots of time and definitely spare them additional stress and anxiety. So nonprofits act as responsible advocates for community interests in legislative and policy arenas and work collaboratively with the private public sectors to improve the quality of life among individuals. But for us as a patient organization to be able to do this, as you know, we are very dependent on donations, fundraising, and contributions from the industry. So this definitely highlights the need for collaborations with the healthcare system for them to invest in this to ensure that these organizations can continue to function in times of crises and provide the needed support and services to the patients. So independent funding should be reserved to support these groups as a permanent part of the healthcare system. Next slide, please. So for the recommendations that were put forth on this question, there is a need for stronger collaboration and partnership between patient advocacy groups and the healthcare system. Both patient advocacy groups and the healthcare industry are working towards the same goal, which is improved quality of life and better patient outcomes. So although there is a symbiotic relationship and each has a unique approach to achieve these outcomes, sometimes their objectives overlap and are complementary to achieving them, to achieving the aim at hand. So the Canadian healthcare system should collaborate with organizations and advocacy groups because they are considered valuable resources for psychosocial support and mental health services for patients, improved clinical trial design, recruitment, and the retention of patients in trials, healthcare and trial navigation for patients, and of course, dissemination of trusted care resources and information. Next slide, please. Question 7, which is our last question and our last theme, is how can a unified healthcare-related research system operating at an interprovincial level be able to handle future healthcare disruptions? So this is something that we all know, but Canada's decentralized healthcare system was not prepared for clinical research disruptions caused by the pandemic. So there were no national guidelines. So each province and sometimes, in fact, each institution was handing out their own set of policies. So our system was not equipped to quickly mobilize its clinical and research workforce, and its response from a scientific standpoint was far from optimal. So in Canada, again, also research is disjointed and works in different silos that are funded based on projects and opportunities. So the disadvantages and basically the downfalls of this framework became really apparent during the pandemic. So federal and provincial governments and policymakers should consider making changes. And those are in the next slide in our recommendations. We believe there should be an allocation of funds in the federal budget to manage future healthcare crises. There's a need to secure continuous long-term funding of health-related research in Canada, instead of having various research groups compete for research grants and opportunities. So there's a need for an infrastructure that allows for, first, timely access to health data, as well as data sharing between different institutions and research facilities. And this was already discussed in question 2 regarding interprovincial data sharing. Federal level data collection, sharing, transfer agreements, and policies to support timely centralized data access. And lastly, provincial research communities to be provided with incentives to collaborate on the development of a system that prospectively collects data. Next slide, please. So our concluding question is basically a summary of what all our recommendations are, but it forms nicely in a question that is, how should a once-in-a-century crisis be met with a commitment to build more resilient healthcare system collectively? So our concluding recommendations are based off of 6 themes of strength, which served as a springboard for building resilience. First being advancing virtual care and digital health technologies to prevent any future interruptions in the delivery of care. Developing real-time data metrics, data sharing, and evidence-based decision-making. 3, enhancing public-private nonprofit partnerships to advance research and strengthen connections across the system. A patient-centric learning healthcare system and research system. Investing in training and hiring of a robust supply of healthcare human resources. And lastly, increasing investment in early cancer detection research and a need to develop a cohesive national strategy and infrastructure in this area. So these 6 themes should enable the rapid adaptation to change and collaboration among care centers, clinicians, patients, researchers, and the industry. It's possible to create a system that doesn't have to scramble for personal protective equipment and ventilators during a future pandemic. So our health systems are considered to be resilient during a crisis only if they protect human life, maintain a high quality of life, produce good health outcomes, and withstand unprecedented system shocks. Next slide, please, and we're almost done. So I like to end it with this sentence, which basically shows that a resilient healthcare system that can respond to shocks and threats is not an emergency system. It's a robust everyday system that can respond to emergencies. And in terms of our next steps, as Barry mentioned, we do have a dashboard project that we just got a grant for. And basically this dashboard displays interactive, near real-time statistics and rates on colorectal cancer screening, diagnostic, as well as colorectal cancer related treatment. And we're starting it in the province of Alberta, collaborating with the University of Calgary. But other next steps that we're always trying to work for is the continuous advocacy for the deployment of the Quebec colorectal cancer screening program. So we do believe investment should be in prevention. And it's quite unfortunate that Quebec has still yet to have a organized and structured screening program. So also continuous advocacy to increase access to clinical trials. And again, when it comes to screening and prevention, we are calling for more advocacy when it comes to expanding endoscopy services to private clinics. Next slide, please. So our question to you today, along with questions that are going to be coming from Anne-Marie, is how do you think CCC can support change in the healthcare system and lead the impetus for change?
Maria, I don't think I've ever heard you speak as quickly as you did today.
Sorry.
Bravo, well done. Thankfully, everybody had the report, but you did a great job to move through a ton of information. So we're going to take a breath here. And before we get into about a 20-minute session where we want to hear from you, is there any direct questions that you would like to ask of Maria on those recommendations, or any other commentary that you would like to provide specifically? Christine, we can always count on you to have your hand up. We so appreciate that. Thank you.
Sorry, me again. I'm just wondering, I'm thinking about, how you're hoping to address the patient-centered approach. And just because of my role, I'm obviously working with a lot of groups. So I see a lot of synergies with some work being done elsewhere by other groups that I think there's a real continuity of voice and purpose that you could all join together on. But I'm also wondering, in terms of, moving this forward in terms of actual policy change, what your plans are to collaborate with some of the external groups and coalitions like the Resilient Healthcare Coalition or other existing groups to really reform policies and move the resilient healthcare system forward.
Yeah, I could just touch on that because I do most of the patient inputs for PCODE or NES. So what I can do from my perspective and from the patient perspective is to, when I do survey patients and get their experiences on a drug that they're on, I do my best to try and ask them very patient-centric questions. So on a scale of 1 to 10, how would you rate your quality of life? Were you able to go back to your just normal routine? What does your daily life look like? Or like basically trade-offs. So would you trade this for this side effect, or basically questions like that. So what we can do in trying to get HTA become more patient-centric and eventually a healthcare system that's more patient-centric is by doing it from our side to try and get a more patient-centric way to get these drugs reimbursed for, not just because of their overall improved survival, but also things that matter to the patient, so the patient preferences. So that's what we can do as a first step. And I know Barry can touch on what we're doing with the Resilient Healthcare Coalition. So I'll leave that to him since he's involved with that coalition.
So excellent question as always, Christine, and thanks Maria and Elia. Great presentations as usual today. Everything that we do is for the most part very collaborative. So we consider our work from the focus of our perspective of colorectal cancer Canada a plug-in to the work of the Resiliency Healthcare Coalition. And in fact, I'm on the steering committee, and various members are with us today as well on that. So it's really kind of we see ourselves as a driver in many of these coalitions, and then collaborative to amplify the work of the rest of the coalition. In terms of patient centricity, this is a very fundamental question that we are working on both in Canada and globally, in fact, through our patient-centered approach to cancer clinical trials. Some of you have seen that through our clinical trials conferences. We'll be launching our website on that called PACT, P-A-C-T, so look for that. And that's where we really look at the patient centricity question very seriously, where patients and patient groups are engaged at the very beginning from ideation of a clinical trial all the way through the clinical trial continuum. And then post-trial to keep in touch with the patient perspective, pros, and so forth, so that we can bring that perspective back to health technology assessment. So we have a national project on that called Patient Values and Preferences, which is based with, again, with different researchers, but at University of Calgary, lots of stuff going on in Alberta. And we're working globally with the Health Technology Assessment International Patient Citizen Involvement Group, Patient Preference subgroup of it. So it's an international collaboration with people from around the world, health economists and so forth, where our project in Canada, our Patient Values and Preferences in colorectal cancer as an example, will be used to exemplify how best to include patient preferences, not only through the anecdotal stories, as Maria is referring to, that Cadith now takes, but how to make it more research-based and work with methodologists to increase our efficacy and our input. But that's from the patient perspective. It's also looking at it from the industry perspective. So patient preferences being included in the clinical trial process, as well as by patient groups as a whole. And this just isn't applicable for colon cancer, but it's for various cancer groups. I just want to there's so many things to talk about. And the work, and as Maria mentioned in our Get Personal program on molecular profiling, is another example of how we engage with patients, nationally, to get that patient centricity and ensure that that patients have access to some of the new precision medicines that Tim was talking about before. So the molecular profiling is fundamental to this, and again, another collaboration with the Beat Cancer Coalition. And finally, Tim, you asked a question before about survivorship, and Elliot responded about our survivorship care plans. We're taking that a step further, and we're advocating for survivorship clinics. In other words, to take the pressure off the healthcare system, take out of hospital clinics where you can do endoscopy and scanning and blood work. And I think these are models which are not necessarily new. We've thought about them before, but have come to light. So I'll leave it with that, and looking forward to a lively discussion. And you know how hard it is for me to stop talking, so I will do that.
Well, maybe I could springboard off of that, Barry, because I appreciate the question, Christine. I know that we wanted to also get from you your perspective around patient centricity and some of the efforts that industry is thinking about applying from their perspective. Even though we've worked very closely with industry in a number of different ways, one of the key quotes that came out of the report was in fact from Pamela Frolick. And her quote was, "It is the patient centricity that will give the healthcare system the resilience it needs." It's a beautiful summarized quote as a statement from industry. So we'd welcome thoughts from anyone who's open and willing to offer from an industry perspective, outside of some of the things that Barry has highlighted. Is there other things that need to be considered to drive patient centricity in the healthcare system? What's on your mind that way?
I can speak again, I guess. So I think your call out around patient coaches is really important, and it's something I'm hearing as a resounding theme. Allcan Canada is doing a lot of work around this, Canadian Breast Cancer Network and yourselves, and just a lot of folks are recognizing the need for patient navigators. So I guess I would encourage you to explore all the different avenues for this. Like, will they be at a patient advocacy level? Would they live within the actual oncology clinics, or should they be both places and somehow be aligned, in their efforts and in their commitments, right? So that there's continuity from what a patient would hear from one place to another, but it is a very large gap. So I think that will go a long way towards patient centricity.
Yeah, thank you, Christine. Is there other points of views, other organizations that are considering innovations as it relates to engaging patients in their conversation?
It's Tim again. You may have already considered this. I was lucky enough to be at a pre-budget consultation for Northern Ontario recently, within which there were a couple of Indigenous leaders, and I'm not sure if the remote communities or Indigenous cultural needs have been taken into consideration in some of these aspects, but I think that might be a good, strong voice that would provide an additional strong sort of community group to help advocate for some of this cancer care closer to home, access through data, etc.
Thank you. Wendy, you have your hand up.
Yes.
Hello there.
Great. Hello. I might be muted. Just one sec. No, I'm not. Okay.
You're good.
Just to say that I think patient centricity has to work across many different constructs and entities. Companies have their obligations to become more patient-centric and genuinely embrace that, and that requires understanding. But I think several of our external decision makers and institutions need to be encouraged to become more patient-centric and not a tick the box. And I'm thinking here of the Health Canada pilot that was done some time ago where patient voice was included. Why can't that go permanent and live? HTA, yes, patient values, but one often senses that at the end of the day, it's more of a cost-benefit analysis and not really the unmet need from the patient perspective, and where can real world evidence and risk sharing work for that. And even, and this is sometimes controversial with who you're speaking about, but the whole PCPA, how can they understand to make their decisions more patient-centric? And then within all of our institutions and even the drug plans, sometimes when individual patient groups contact a drug plan because something is delayed in listing, they often get a very paternalistic and almost condescending response. So I think all of these systems have to be engaged and encouraged to be more patient-centric within themselves to kind of up the embedding and the IQ across our healthcare systems. Thank you.
Yeah, thank you so much, Wendy. Beautifully articulated. I want to point to the chat box. Eva has shared in the US Cancer Coach as a part of the primary care models, and she's given Laura Health as an example. So if you haven't seen that and you want to know more about it, Eva's provided that link. I'm going to bridge out of this conversation slightly because I can feel that there's a lot of passion for patient centricity as a priority. When you read the report, there's 7 questions. In fact, there's a summary questions times 5 or 6 recommendations. It's hard to know where to begin. And so if I ask you to put your industry hats on, and if I ask you to suggest those 2 or 3 immediate, short-term, impactful steps that, particularly in a collaborative way, building on something that you had said, Christine, what are those things that industry is interested in doing? What are those things that, as an industry working collaboratively, we could take a step towards? Clearly, patient centricity has generated a lot of specific conversation, but is there other things? For example, advocacy. For example, data sharing. Is there other things that spring to mind? Anybody putting their hand up? Alex, thank you.
Hi, and thanks for the invitation today. This is fantastic work. I think, to answer your question, so much of this depends on the availability of the data. I really am drawn to the whole idea of having real-time data. I think, when you flagged it through the pandemic, we see, COVID cases every single day, and it drives everything right now. And, the idea that we could have something like this for cancer and be able to see that, again, that to me is how you're going to drive the awareness. You're going to get engagement, you're going to get movement. But until until we can get to that point where we can have that real-time data, I think it's great anecdotes, but they're anecdotes. Like we really need to find a way to how do you make this real for so many people? Because again, cancer, everyone's saying, this is the next pandemic, and how do we, can we use the real-time data we have? I love that, and that you've got this grant in Alberta, because I think that's going to drive a lot and have a lot of impact.
Thank you. I don't see any other hands up at this stage.
Two more.
Yeah, I'm sorry, Tim, you've got your hand up. Thank you.
Two industry items, and it sounds like they're very well linked with the pathways you're heading down already. But treatment closer to home. How can we make that patient experience better, which would also alleviate a lot of the personnel constraints at the academic centers, and just holding governments like the government of Ontario accountable for delivering on some guardrails at a minimum to facilitate interoperable and accessible data for patients, which would then facilitate the integration of data that would be available for researchers. I think if we make it about matching equity of patients in places like BC that can access their own personal data through a health portal, I think that would really draw that forward faster, which would then facilitate the availability of consolidated real world data, which would then allow us, the ability to say funding for this rare cancer can be based on our consolidated data across the country and our consolidated experience. But I think if we make it about the patient and equity to other regions, then I think we'll get there faster.
Yeah. Barry, you have your hand up. Did you want to provide a comment to that?
Yeah, just a couple of comments. So, first, just to respond a little bit to what Wendy said, this is a really essential and very opportune time, I think, to look at the infrastructure in Canada and how it might be reorganized, especially when we look at the delays, not so much at the regulatory level, because I think the Project Orbis and so forth may help to advance that, but downstream from there, between PMPRB and CADTH and INES and PCPA, until it goes through that process and then gets a listing, the time is 2 to 3 years, and this is totally unacceptable. So I think it's a very opportune time as the conversation hopefully shifts away from PMPRB and onto other things, that we can maybe work together to plan for or propose a new restructuring of that, maybe a simplified process, no less maybe onerous, but certainly simplified, so that we get effective drugs out to people in a timely manner. And that is something, as many of you know, that is close to our hearts. Conditional approval subject to the collection of real world data, and this is really fundamental to it. So thank you for bringing that up, Wendy. I think that's really important. But also, Christine, you brought up the question of clinical trial navigators. We know that in most hospitals we have question of drug navigators to get the drugs to the patients, but very little about assisting patients to have access to trials nationally. Sometimes we have that within the province or within the hospital, but not necessarily nationally. So we are working together with the pilot project in Windsor, and we have various collaborators in Quebec that we're going to be working with, as well as some other national ones through our patient-centered approach to clinical trials, in order to see how we can start to develop a clinical trial navigator process or system for patients. This is a big gap in the system, and as many of you know, clinical trials were interrupted during the pandemic. So again, another opportunity to correct something that was not working well or did not exist even before.
Great. We are actually approaching the end. We want to be respectful of your time today. I think that this is really just what I call, we've lit a fire, and we want to continue to see the fire burn in a good way, I might add. on bringing the recommendations alive. So I guess a question, which is a very difficult one to answer as a broad group, is really what role does industry see itself playing? How can we actually pick up the torch to carry these recommendations forward? I know that there's several different reports like this that have been in the market, but I think I speak very succinctly for CCC when I know that Barry and his team wants to be one of those torch carriers. So I would encourage everyone who has been exposed to this report to digest it, to link back with the organization with what I call the offer of what you feel you can do, what it is you want to do, what it is important to your organization to carry forward. These recommendations were robust in so many different ways. And where we start and where we move towards over the next couple of years, I think is fundamental. So I encourage all of you to call Barry, call Carol, call Maria, call Ellie as you feel a need to express your voice and to help lift this initiative up. Is there any final questions or comments that people want to make before we sign off?
If I may, CCC always does a fantastic job of knowing what the key issues are and having a plan forward. So thank you for the clarity and the consults. And Barry, I've lost track of the decades that you've been helping the community, but it's always appreciated. So thank you.
Thank you.
Right. I would be remiss if I didn't suggest that a paper has been generated. Ellie and Maria, it's going for publishing soon. Everybody involved here will have be in receipt of that as well.
Yeah, I can do either one of these two things. I can send it to you right now, but you'd have to keep it to your eyes only. You can't share it with anyone because it hasn't been accepted.
That's
yet,
a big ask for 28 people.
Or we can wait until it's published. And then we can share with everyone.
Okay. Barry, any closing remarks?
I wasn't sure of the time limitation, how we were going, and people might start to drop off. So I put a little something in the chat to thank you all for your enduring support and trust in the work that we do at CCC. I know we always come back to you and say more. That I guess that's part of our job. But really, I know that with each and every one of you, when we start talking about our projects, that your own hearts are in these projects. Of course, everybody has their corporate restraints. We understand that. And that's why we say that regardless of the support, it's your input that we really want. The support is fantastic. That's what makes it happen for us, absolutely. But it's your insights like we had today, or great questions. And I know that this is just the beginning of this project, as you heard a little bit about some of what we're doing going forward. And we'd love to hear more about public-private partnerships, how we can work together. Many of you know that we are big advocates for public-private partnerships in research in Canada. We want to ensure that your drugs are developed here, that our patients have input in the ideation of the trials. As hard as that might sound, it's still possible that we can work together to bring that patient input when it comes time, not just at the regulatory, but also at the reimbursement stage. But most important, we want people just to walk into hospitals and the drugs are going to be there and not think about all the things that we have to think about behind the process. And we want Canada to be a leader in that way. So thanks again.
Okay. We will close on that. Thank you, everybody, for participating, and please reach out for further conversation to either Barry, Carol, Ellie, or Maria.
And thanks to our team. Thank you.
Bye.
Awesome. Thanks, everyone.
Thank you.
Bye-bye.
Bye-bye.
Thank you.